So good evening, and welcome to the IMF's Living Well with Myeloma teleconference. It's our second teleconference this year, and tonight our wonderful panel will address your top concerns. Our speakers tonight are Dr. Brian Durie, Chairman of the Board of the IMF, and joining him are Dr. Vincent Rajkumar from the Mayo Clinic in Rochester, Minnesota. And also we have Dr. Rafat Abonour from Indiana University Simon Cancer Center. By the way, this is Susie Novus welcoming you. This teleconference is part of Myeloma Action Month. Lots been going on this month. And I want you to know that it's great that all of you are taking action by dialing into the call and becoming informed and empowered. I'd love it if you take a look at our Myeloma Action Month website for all the options that are available for you to take action on. Just go to mam.myeloma.org. And each of our actions increase awareness, and that's what we wanted to do, increase awareness about multiple myeloma. Before I turn it over to Dr. Durie and our wonderful panel, I'd like to take a moment to thank our sponsors for tonight's teleconference: Amgen, Bristol Myers Squibb, Celgene, Janssen, and Takeda Oncology. It's really wonderful that they support this program, and it's greatly appreciated. One last thing, as a reminder, you'll find the link to tonight's slides by going to our website, and under New and Noteworthy, which is on the right-hand side of the page, it's the first bullet down. That's the link to the slides. Just click on it, and you'll be all set. So now, sit back and relax, and I'm going to turn it over to our wonderful doctors. Brian?
Well, thank you, Susie, for that great introduction, and I'm very pleased to have Dr. Rafat Abonour and Dr. Vincent Rajkumar joining me tonight for this unique session. We've never done this before, where we've had three panelists addressing the questions. And so if we can start with what is slide number 3, just to introduce what we're going to cover tonight. This is Top Questions Needing Answers, Episode 1, implying that we are hoping and anticipating to do this again. The structure for this evening is that we are going to focus on how to use the newly approved drugs. There has been a lot of discussion about these new drugs, the approval in November, except for Faradex, which was last year, but the recent approval of the 3 new ones has led to a lot of discussion, but what has not been really discussed is really how do we expect to be using those drugs, and how well do they work in different situations. And then the second point here is what is the most exciting, best future therapy beyond these agents which have just been approved. The structure will be that we will go through the 4 approved drugs, and then we will turn to the CAR T-cell question, and so there will be basically 5 segments on the call. After each segment, I will turn to Rafat and Vincent to ask their opinion about each of the drugs, and then we will open the lines, and as much as possible, we'll try to take questions from you calling in at that moment. So we'll try to get those teed up for each of the drugs. So, slide number 4, the agents that we're going to talk about mostly today, those are the 4 new agents, and those are Faradex, which is panobinostat, Darzalex, which is daratumumab, Ninlaro, which is ixazomib, and Implicity, which is elotuzumab. If you look in the middle column, you'll see that these are all approved relapse setting, different phases of relapse. The top 2 were approved in the relapse refractory setting, the bottom 2 in earlier relapse settings, Ninlaro with 2 prior therapies, Implicity in the earliest setting in the 1 to 3 prior regimens situation. A key difference between these agents is that Darzalex was approved as a single agent, and so this is a classic approval where it was approved in the situation of what we would call an unmet need. It worked as a single agent in patients who had received all of the previous therapies, patients who were truly refractory to prior therapy. The other 3 agents have been approved in combination, the Faradec in combination with Velcade-Dex, the other two in combination with Revlimid and Dex, and they are approved in a relapse setting, but not necessarily in patients who have truly failed all prior therapy. So a little bit different scenario for each of those agents. On slide 5, I want to highlight kind of where we are in the decision process with these drugs. Obviously, patients always want to voice a preference, which is appropriate. At the moment, we do have data from research for these drugs, but right now, that central decision process is very much impaired because we actually do not have that much clinical experience with these drugs. At the recent patient seminar in Seattle this past weekend, only a handful of patients in the audience of, 150, 200 patients had actually taken any of the new drugs. And so we're just starting to see patients experience and understand how these treatments can work for them. The next 3 slides will kind of summarize, well, what are the options for patients who have relapsed or relapsed refractory myeloma? And on slide number 6, I list first relapse. So if a patient has gone through initial therapy, what would be the options if they relapse? Well, obviously, always there could be an option to participate in a clinical trial. Then the breakdown in the 3 blue boxes include the idea that if you've had Revlimid, so an IMiD-based regimen, then possibly you could have a Velcade or a proteasome inhibitor type regimen. And if you've had Velcade, then maybe you could use a Revlimid-based regimen. So obviously the choices depend on what has been the previous drug or drugs used and what has been the response to those drugs. And you'll see with the yellow arrows, I've pointed out that for patients who have not received Revlimid or have been sensitive to Revlimid, Len naive, the ixazomib Revlimid-Dex combo can be considered, so IRD with the yellow arrow there. For patients who have had limited exposure to bortezomib or Velcade, interestingly, the IRD is also applicable because the ixazomib could be useful in that setting. And then you can see underneath that, if there has been previous exposure to both Revlimid and Velcade, Len-Bor, then the panobinostat could be an option there. And off to the right, you can see that obviously if a patient has done well with transplant, that could be again considered. If you look at slide 7 with more advanced relapse, you can see that many more complicated treatment regimens can emerge, and this was where it was just so exciting to see that daratumumab, which I've listed with the arrow at the bottom, worked in what we call dual refractory patients, patients who had failed after lenalidomide or Revlimid combinations or bortezomib Velcade. And so patients who had had extensive prior therapy, refractory, did respond to the daratumumab. So very, very important option in that setting. The next couple of slides, just to set the stage completely here, is a summary of, well, what are the options for patients who have relapsed? And I think it's helpful to look at all the different single agents, doublets and triplets, different combinations that could be considered in patients who've had different treatment exposures, so that if there have been 2 different therapies, 3, 4, or 5 different therapies, you can see that in patients who've had 2 prior therapies, there's a very good treatment option there with the red bar. That is carfilzomib, Revlimid, and dexamethasone, which has an 87% response rate. So this is a very, very active regimen in patients who have early relapse. And if you scroll down to the bottom there, you'll see another red bar, which is in patients who've had 5 prior therapies, and they can do very well with carfilzomib, pomalidomide, and Dex. And you can see that pomalidomide and Dex and carfilzomib and Dex, those doublet combinations are also active in that setting. So we do have some things to be considering for relapse patients. And on slide 9, then you can see that this can contribute to significant remissions and survival. In the earlier relapse, you can have remissions lasting 2 to 3 years and correspondingly good survival with that red bar at the top. And down at the bottom, you can also have significant responses and survival in this relapse setting. And so the question is, with this background, how should we be looking at using Faradex, panobinostat? And so that question is on slide number 10. The trial data that we use to think about that is shown in slide number 11. And so this is the Panorama trial, and this is with the panobinostat, and the panobinostat and Velcade and Dex are compared with Velcade and Dex, a large study, 768 patients, and you can see these are patients who were not resistant to the Velcade, so they were what we call BOR naive or BOR sensitive. In other words, they may have had Velcade or not, but they were not resistant to the Velcade. And if we go to the next slide, slide number 12, the key results, I'm just giving you the top line information here, almost literally. You can see that the top line there says Panorama 1 results, median PFS months. So what that means is the length of the remission, panobinostat Velcade Dex 12 months, Velcade Dex alone 8.1 months. So basically a 4-month improvement in the remission with the 3-drug combination versus the 2-drug combination. If you look down to the bottom, a very important thing about panobinostat when it was reviewed by the ODAC committee particularly is the side effects. And you can see there were significant diarrhea, fatigue, and neuropathy side effects. And I would also mention significant low blood counts, particularly low blood platelet counts with this combination, which made it a challenge to adjust the dosage and schedule to get the wanted benefit. In thinking about using panobinostat, a final point in slide 13 is that we do have some other options right now. There is a new HDAC inhibitor, which is what panobinostat is. There's a new specific HDAC6 inhibitor, which is called reconolistat, which is in a couple of trials right now and is showing benefit in combinations. And so an option for a HDAC inhibitor would be to consider one of the trials. And then also at the bottom, I will be interested in my colleagues' take on this. There's also a study showing that panobinostat can help in combination with carfilzomib and Dex versus Velcade and Dex. And so this gives you the background of what's available and the information specifically about panobinostat. And so, Rafat, let's start with you. How do you feel about panobinostat, and when do you recommend it?
Well, first of all, good evening, and thank you for inviting me to participate in this important conference. This is a great time for myeloma. That was a year to remember, I think. We have, amazing drugs being approved. Although it's a great time, it's more confusing time to people who are taking care of patients. And I think we always have to, measure progress carefully and always reevaluate our progress and what's our goal. It's great to see that we're delaying progression, that means relapse of myeloma, and maybe improving overall response, but we really need to measure that again as toxicity, both at the patient level and the financial level, the extra cost of therapy, but more importantly, the extra cost to the patient in terms of the side effect. So from a scientific standpoint, improving on bortezomib, Velcade activity is very important. What we need to do is to really measure that in more robust clinical trial to make sure that we have a meaningful improvement in the response quickly with minimal toxicity. So I think it's a step forward, but one needs to be careful and assess the patients when using these drugs carefully to balance the benefit and the side effect. So I wouldn't jump the gun, and everybody who needs to be on bortezomib need to be treated with penovistat. But I think it's important to see if the patient is responding well, for example, to bortezomib dex regimen. That's great. If they're not, then what can I add next, and what are the side effects? And we always have to measure the activity on a monthly basis. We can't just keep patients on treatment for a long time and then 3 months later say, well, okay, what was your response? I think it's on every cycle, the patient needs to be assessed for response and for toxicity. So I think the progress is being made. It's an interesting and important drugs, and maybe the next generation HDAC inhibitor will provide more specificity and less side effect.
Okay, very, very helpful. So Vincent, what is your take on the information so far, and where are we headed with the HDAC inhibitors?
Brian, panobinostat is one of the few drugs that we have approved that does not have single-agent activity. However, this is a very large trial, and it did show progression-free survival improvement. So I have been using panobinostat in patients who have become refractory to proteasome inhibitor-based therapy or proteasome-IMiD combination-based therapy, such as BRD, and basically adding it to that regimen to see if I can rescue a response. And we have had some success in that regard, and that's where the trial results are also showing that patients previously treated with both IMiDs and bortezomib more than 2 lines, that's where the greatest improvement was. But I tend to add it to whichever regimen that they were on to see if I can improve it. Couple of tricks that I have tried to do is reduce the dose of panobinostat to 10 milligrams when starting for the first week, and then increasing it to 20 if there is no diarrhea. Right. And also trying to use thalidomide instead of the other IMiDs, because thalidomide has this side effect of constipation, which can sometimes counteract panobinostat. And one of the big successes with that approach I have reported in the American Journal of Hematology with a multi-drug combination. And of course, with using it with carfilzomib instead of bortezomib means you can eliminate the neuropathy. The neuropathy and the diarrhea were the 2 big problems in Panorama 1, and these are the 2 ways I've been able to overcome that.
Okay, very, very helpful. And so, Lisa, do we have any immediate callers on the line with questions on this topic?
And if you would like to ask a question, please press star 1 on your telephone keypad. And we have one from Nancy Rochester.
All right, Nancy, what's your question? How can we help you tonight? Thank you for joining.
Yes. Well, thank you for presenting. I was diagnosed over stage involvement, as well as anemia and fractures, and I've relapsed after 9 months of chemo, and I'm in treatment right now with Dex and Velcade. These new medications, my next course is Mayo Clinic. Am I right?
Monoclonal antibody, yeah.
What are these drugs, these new medications, etc., that are being discussed tonight? How is the impact on someone's kidney if they have kidney issues?
Okay, good. Well, we are going to. That's actually our next topic.
Oh,
we're going to talk. No worries. I mean, what we're going to do now is talk about a couple of the exciting monoclonal antibodies.
Okay.
We can definitely touch on if the impact of kidney problems. So maybe we should reserve that, and we can try to answer that as we move into these next couple of drugs, okay?
That's great. That's perfectly fine.
Okay, good.
Thank you.
I tell you what, why don't we go ahead to keep things moving? And so the second agent that we want to talk about tonight is slide number 15. There are 2 targets on the surface of the myeloma that have led to drugs which are approved, CD38 and SLAM-F7, and slide number 16 is about DARA, which is short for daratumumab, which, as I mentioned here, is a human IgG manufactured antibody against CD38, which binds it and obviously directly and also recruiting the immune system really effectively treats the myeloma. And slide number 17, which is results that were presented at ASH this past December by Dr. Saad Usmani. He showed that using the 16 milligram dose of the daratumumab as a single agent, he looked at the combining two studies with those results. The final response rate was very exciting. There was a 31% of the patients had at least a 50% improvement, and of those, 13% had a 90% improvement, and there were some even that did better with a complete response or better. And so this was really what caught everyone's attention as a single agent in different subgroups, age, prior lines of therapy, refractory status, and also renal function was studied for our last caller. Really important benefit. On the next slide, I show how long did the remissions last, what we call progression-free survival, on slide number 18. And you'll notice the kind of lilac kind of curve at the top, which shows that for responding patients, they stayed in remission. The average was 7.4 months, so that patients were staying in remission for over 6 months. And then if you go to the next slide, the survival, the responding patients had an average survival which was close to 20 months. So moving forward, I suspect the true median is going to be right around 2 years. And so really, really exciting to see the impact of a single monoclonal antibody in this refractory setting. And in addition to that, I'm not going to show you all the data. Combining this with a variety of agents, with pomalidomide, with Revlimid, and other agents, has shown even more impact and prolonged remissions. And so, if we go to my next slide, 20. Vincent, how do you look at all this information? Obviously an exciting new drug, a new class of therapy for myeloma. How has this changed the treatment for myeloma?
Brian, daratumumab is probably one of the most anticipated myeloma treatments. It does have very high single-agent activity even in very refractory patients. So I'm very optimistic on this drug. We have been using daratumumab quite extensively, and I'm impressed at how many patients we are now able to help with the availability of daratumumab. We are using it as a single agent if there is a patient who has a relapse that is indolent but it's occurring after multiple prior lines of therapy. We are using it in combination with pomalidomide and Dex, or several other regimens if the patient's having more aggressive relapse. I anticipate the daratumumab will quickly move earlier and earlier in the disease course and probably even into frontline therapy, very similar to the path that rituximab took in lymphoma.
Right. Yeah, so very exciting. And Rafat, I'm sure you're also excited. What is your take or experience so far?
Yeah, I mean, I share the excitement of Vincent and yours, Brian. It's a very important drug. I'm really pleased with the activity in those patients who really failed everything in front of our eyes. I'm impressed by the activity in frail elderly patients who actually have low white, counts, because it's very hard to treat them with chemotherapy when they have low white count or low platelet count. So right. It's a very active drug, well tolerated. You need to monitor with the first dose. Sometimes I use lower concentration the first time just to make sure the patient get used to it and see what they need to tolerate it. But then after the first dose, I think they tolerate it fine and the infusion go faster, and quite impressive, the response.
Yes. So the infusion issues, obviously the biggest concern with that first infusion, but any ongoing concerns or issues that you have seen?
Not here. I haven't seen anything at IU.
Right. Okay. All right. Well, I think we have some time here. So, any questions about daratumumab, Lisa? If we can get any patient on the line for that, we'll see any questions about Dara.
And again, that is *1 to ask a question. You have a question from Meredith Dale.
Okay, Meredith. How can we help you?
This is this surprises me, Doctor. I'm so glad to hear you all talk, and I've just got. I have not a question. My husband just started out, and he's taking Revlimid now, and
Okay.
it's knocked him right off his feet. Is he going to get? Do you get immune to it, or will he be able to take it better as he goes along? This is his second regimen, but he is not. I'm sorry.
Okay, well, this is early on, obviously, and
Yes.
so I think that Revlimid is a great drug, and hopefully he can do well with that. But as was mentioned by Vincent, I think that we're starting to think about the daratumumab could add in earlier and earlier if needed, and so certainly the daratumumab, which we were just talking about, can be available and could be added in if things are not going as well as they need to.
Thank you very much.
Okay, any other question about daratumumab?
You have a question from Shirley.
All right.
Yes,
Shirley, yeah.
I was diagnosed in 2007. I've been doing really well, except I took Revlimid and Velcade. I had blood clots from Revlimid, and I had an allergy to Velcade.
Okay.
My treatment since 2013 has been blood transfusions. I'm only, and I'm scheduled.
Okay.
And I'm scheduled to go on daratumumab, but I need to know. There were some things that I needed to know what the side effects might be from it. I understand that there are fewer side effects on that than there are on Velcade and Revlimid. I'm old, but I'm not frail.
So if you don't mind, how old are you? Just if you don't mind.
No, I don't mind at all. I'm 83. I just turned 83. I have
83,
a job.
okay.
I work.
Okay.
Happy birthday.
All right. So Vincent, this is an 83-year-old lady who is concerned about the side effects of Dara. Has been off treatment for a while, sounds like. What do you think?
Have you taken any treatment yet, or you're just about to start?
I have not taken Dara. I had Revlimid in 2012, I think it was, and Revlimid I had multiple blood clots in both lungs from it.
Okay.
And then in 2013, I had Velcade, and it just knocked me right off my feet. I was hospitalized for about 5 days. Had a pretty bad allergic reaction to it.
So daratumumab, usually the main problem is only with the first dose, like Dr. Abonour mentioned. The very, very first time you get it, you may have chills, fevers, things like that for the first day. And they will adjust the dose as needed to minimize those side effects. About half the patients getting daratumumab get those kind of reactions that are quite severe. But after the first dose, then the second dose, very few patients, less than 5% ever have serious reactions, and then it drops off. So it's one of the more well-tolerated treatments, so I wouldn't worry too much about the side effects. They just have to be careful with you, given your age, and all about the first dose treatment, the very, very first dose.
Okay. Thank you. So don't be too nervous. We're optimistic this can go well for you, okay?
I am too. I'm rather anxious to begin on it. And how long should I look for those chills and fevers the first time?
Yeah.
Maybe how many days or?
Well, they'll talk to you about it, but it's mostly at the time of the infusion and shortly thereafter. But they'll be watching you closely for that, and hopefully will not be too severe. They'll give you preventative for it, okay?
Okay, thank you very much.
All right, maybe I have time for one more quick question on Dara, if there's someone on the line.
Yeah, I have one from Brenda Jenkins.
Okay, Brenda?
Yes, thank you so much for offering this call for us. My question is, I have been on a couple of treatments, and the one thing I noticed on multiple treatments is they use Dex.
Yes.
Which I have gained weight on. So this Dara, is that how you pronounce it? Really sounds, that single agent really sounds pretty good for, well, I guess I shouldn't say that. Do you think that would be pretty good, if the relapse again?
Yeah, so Rafat, this is a good point. It could get a patient away from Dex, which could be good news, right?
Yes.
Yeah, I mean, obviously we need to, it would be nice to eliminate Dex. Sometimes, unfortunately, for example, when we use daratumumab, we have to use some steroids like dexamethasone to reduce the infusion reaction, the chills, and things like that. Hopefully one day we will use very small amount of Dex, which can be important to alleviate some of the side effects, like the nausea you see with chemo and things like that. Unfortunately, for a long time, dexamethasone and steroids were the major player in helping us control the disease, but now probably with all these nice combination, we can use very little, if any, of those steroids.
Yeah,
okay.
Great. All right.
My concern was with gaining weight like that, that becomes a problem too when you gain too much weight. There are other issues that come up because of the weight gain.
Right.
Yeah.
Absolutely.
Yeah.
And that's an issue. So with less Dex, you'll have an opportunity to work on that and maybe get rid of some of those different side effects, which are so troublesome. Yeah. So I'm going to move on now so we can cover the other important drugs. So Dara, very exciting. The third drug that I want to touch on is the drug Activism with the trade name of Ninlaro. The last part is oral backwards to remind us that this is an oral drug. This is the first proteasome inhibitor. It's the first drug like Velcade that can be taken by mouth. So very exciting. And so the study which I have on slide number 22 is the Tourmaline MM1 study, which compared the combination of the Activism with the Revdex versus the Revdex alone. And again, these are patients who were not resistant to Revlimid, so that there could be a benefit in the RD arm. And so if you go to the next slide, top of the line, slide number 23, again, we see the added remission benefit, the median PFS, IRD 20.6 months, RD 14.7 months. So basically, a 6-month remission benefit with the Activism combination, and it's noted there that this was occurring including patients with high-risk cytogenetics. So this was quite encouraging, the fact that it is by mouth. And I would also mention on the slide here, you can see at the bottom what we call the AEs, which are the adverse events, really quite well tolerated, and we can see what our guests have to say about this, but my experience has been rather well tolerated with regard to neuropathy, which is a very important point compared to Velcade, even sub-Q. And so, Rafat, perhaps you can give your opinion first about how you see the role and the benefit with Activism, with Ninlaro.
This is really a very exciting drug because obviously you need an effective drug in this class that can be taken as a pill. One of the most difficult things for a patient is to really sort of have to run to the clinic twice a week or once a week to get infusion. You have to wait for the labs, then you do vitals on you, and then you get the injection or IV, and then you spend half of your day there. On this drug, the nice thing about it is that you just take 3 pills a month, once a week, 3 weeks on, 1 week off. And you can see the amazing result that when you use it in combination. I have an amazing example of this 84-year-old who had a horrible time tolerating Revlimid, and she just does not want to keep going to the clinic. And when she progressed and her disease came back and she became anemic, hemoglobin down to the 8 grams and her myeloma protein up to 2.5, we offered her this treatment. She took 3 pills with only small dose of dexamethasone of 12 milligrams, and her hemoglobin came up to 10, her M protein down to 0.5 in 1 month. So clearly a very effective drug. We can use it with steroid small dose, with lenalidomide. I think there will be amazing combination down the road. But I'm excited about this drug because it does offer great opportunity for a patient to avoid being in the clinic several times a month. It's well tolerated and only 3 pills. It's amazing.
Yes, so I would certainly agree. Vincent, do you echo those feelings?
Absolutely. I'm, again, very pleased that we have an oral proteasome inhibitor, which makes it very easy for patients to take the medications. The main problems we have right now are that the approval is quite restrictive, and therefore we've had some insurance issues with patients not being able to get it with other regimens besides ixazomib, Lendex, and besides, the approval stage of the disease. Hopefully with additional trials, a frontline trial of Lendex versus ixazomib, Lendex has completed accrual and is waiting analysis, and if that drug gets approved through the FDA, then we will have it available for frontline use. This is a safe drug as well, and again, I'm already starting to use it in patients where they don't have to be refractory to bortezomib, but if they have a difficulty in getting to the clinic week after week, then, because of age or distances of travel that's required, then this, if insurance permits, then this is a great way of doing it.
Right, really, really good. So do we have any question on the line about ixazomib and Ninlaro? Anyone have questions on that?
And again, that is *1. You do have a question from Jack Iola.
Okay.
Yeah, close enough.
Good evening, Jack.
Hi, Jack.
How are you all doing?
Fine, thank you.
At the Seattle seminar, the question came up about maintenance with Ninlaro, and wondering if there could be a clinical trial of Ninlaro versus Revlimid. And part of the response was that, well, they're from 2 different drug companies, it would be hard to fund it. But I was thinking the Endeavor trial, which I believe has faricimab versus Velcade from 2 different companies, head-to-head with one another. And so is it really unlikely that there would be a maintenance trial of Ninlaro versus Rev?
Okay, I think obviously good question, Jack. I think that maybe Vincent, you can take this one. I think one of the issues with the maintenance aspect is to show not just the remission benefit, but also survival, which makes it a particularly long and challenging trial. But Vincent, you want to comment on that?
Absolutely. There is a trial that is going to be done by the cooperative groups, which is Ninlaro plus lenalidomide versus lenalidomide. So that's ixazomib, lenalidomide versus lenalidomide.
Yes.
Right. I don't think there is any trial that is planned head-to-head comparing ixazomib versus lenalidomide.
Right. So that trial is actually the one which will be led by Jatin Shah Swag, actually. And, you know, it is frustrating that looking at the endpoints, it'll be a while until we know. You know, the good news is that there's a lot of benefit. The bad news is it takes a long time to find out the magnitude of the benefit. But
perhaps you're looking at two very expensive drugs for maintenance together.
Absolutely. Yes, very expensive, and so, yes, time-consuming to find out, and it would be an expensive way forward if it does turn out to be beneficial. Yeah. So tricky, yes. So I think that we're going to have to move on now to our final of the four main drugs that we wanted to talk about, and so. The fourth drug is another monoclonal antibody approved in November, in the bumper month of November last year, and so this is on slide number 25. What's ELO? ELO is elotuzumab, which is another monoclonal antibody, in this case against something called SLAM F7, which sounds very aggressive, but in the picture there you can see that the ELO monoclonal antibody not only tackles the myeloma, the malignant plasma cell, but also links to the NK cell, the natural killer cell, and so there's an effect against the myeloma, but possibly more importantly, enhancing the natural killer effect against the myeloma. Now, unfortunately, elotuzumab does not really work too well by itself, and again, like the other drugs we talked about tonight, is used and was tested in combination. And so in slide number 26, I show the ELOQUENT 2 trial, which evaluated the benefit of elotuzumab plus Revdex versus the Revdex alone. And again, the comparison on the next slide is to show how much longer the remission and how much better the survival was related to the three-drug ELO Revdex versus the Revdex alone. And you can see the results at 1 year and 2 years, what we call the PFS on slide number 27. 68% versus 57%, 41% versus 27%. You can see that patients are clearly staying significantly longer in remission with the three-drug combination, and then at the bottom with the different colored bars, you can see that this was associated with some deeper levels of response with the blue three-drug combination. And so very, very similar to what we've been talking about, a three-drug combination showing added benefit, this time with a new monoclonal antibody. And so the question, again, on slide number 28, and Vincent, I think you're first up on this one. So how do you see the role of elotuzumab? This is a monoclonal antibody not with single-agent activity, but with important combination activity.
Yeah, this is one drug which I think is still searching for an indication.
Okay.
I am afraid I have so far not recommended it to too many patients because most of the time, whenever I'm thinking a patient may be benefiting from an antibody, I've been picking daratumumab, which has single-agent activity. I must say, a couple of things is that we have 4 triplets now: ixazomib Lendex, elotuzumab Lendex, you have bortezomib Lendex, and carfilzomib Lendex, and no one's doing a head-to-head of 2 triple combinations to find out really what is the best option.
Yes.
And rather it seems like all physicians like all combinations, but eventually we have to pick one, and I think it's becoming very hard to pick one except by opinions. So until these trials are done, there are so many subtleties in how you decide on a regimen, as you showed, Brian, in your slides, depending on whether the patient's previously proteasome inhibitor exposed, are they naive to proteasome inhibitors, have you how well did they tolerate each drug, to deciding which. So there's quite a bit of an art to picking the regimen right now. I think there are many patients who might benefit from ELO-RD or elotuzumab-based regimens. At Mayo Clinic, in the msmart.org page, we have put ELO-RD for frail patients who are relapsing off of Revlimid therapy. So these are patients who got a year of, say, a triplet regimen for newly diagnosed myeloma, and then they are relapsing a year or so later, and they are frail. So we would pick ELO-RD or ixazomib-RD rather than, say, a more aggressive regimen like carfilzomib-lendex. So that's one area. There are also trials thinking of combining ELO plus daratumumab to, in really refractory situations, trying to improve the response.
Right. And in fact, we have a SWOG trial where ELO is added to VRD for the high-risk patients. Yeah,
correct.
That is ongoing. But Rafat, what is your take on this? What is your experience? What are you seeing for ELO?
Well, that's not an easy question. I share Vincent's sentiment. I actually haven't, found a way to recommend it routinely. I mean, I think if you have somebody with very active disease, you want to try to get the most powerful combination to the patient, and you want maybe a combination of drugs that probably have single agent activity. I think if we believe that this drug ELO does enhance natural killer cells and the patient immune system to eradicate disease, it may be a useful drug in patients who receive, for example, a second transplant, and you're trying to give them some maintenance that may be capable of enhancing their immune system. You can combine it with, Revlimid or pomalidomide for a year to see if you can. But we really need more study to understand where can we put this drug and how can we improve on its use.
Right. It's really reflecting something that was different about the FDA approval process. And maybe, Vincent, you could comment on this. Up to now, we've mostly been looking at drugs where drugs were approved on the basis of an unmet need. Whereas in this case, we're looking at a drug which had really been enhancing outcomes in a certain relapse setting, but was not truly in that whole unmet need situation.
That's correct. I think if you are in an unmet need situation, like a patient with the cohort consists of patients who have failed all other prior regimens, then a company can get a drug approved based on single agent activity in a small phase 2 trial, as it happened with daratumumab or even with bortezomib when bortezomib was first approved. In drugs like panobinostat and elotuzumab, the bar is higher because they don't have single-agent activity, so it requires a fairly large phase 3 trial and to show a significant improvement in progression-free survival. With the latest update, I believe ELO is active. I mean, it is active. It's just the problem is we have so many other active drugs. In the phase 3 trial, ELO prolonged PFS, but it also prolonged overall survival.
Right.
And it may have a plateau in the progression-free survival curve, which means that a subset of patients on ELO may benefit much more than you would anticipate. And, if you can take a subset of patients and give them a very prolonged remission, that's a very good thing. And so like Dr. Abonour was mentioning, we have to explore, situations where you use Lendex. Can we use ELO Lendex instead? Or can we use Ixa Lendex instead so that patients can stay in remission longer? Problems with that kind of an approach for me would be like cost. When you combine 3-4 drugs, it really adds up.
Right, exactly. So we have time probably have a quick question about ELO. Do we have anyone on the line who would ask about ELO?
Again, that is *1 to ask a question. That is *1. And you have one from Edward Horrick.
Okay, Edward, we're glad to hear from you.
Mine goes all the way. She goes all the way back to the Daralex. So I'm on Daralex. I'm not on ELO. So
okay.
But I did have a couple of questions on the Daralex, but I don't know if you want to go back there.
Maybe. What kind of question did you have? Just so we know.
very quickly, I'm on it now. I'm into the 2-week treatment. What happens if the numbers start to slip once I go to 1 month?
Okay, a good point. Who would like to take that one? So some early benefit, but then maybe not being sustained.
Correct.
Well, we don't want to give, it's very hard to give us advice for one single patient. But in general philosophy, some of the tricks that we try are to go back to a more intense schedule, like every 2 weeks instead, or maybe add another drug. And so we work with you to try and unless the relapse is very aggressive, we try and keep the data on board and try and see it work with the regimen to get you to a response again.
That's what I was wondering, if you would go back and, go back to 2 weeks.
Go back to 2, yes. I think definitely could consider 2 weeks. And as Vincent said, I think a number of us have looked at maybe adding in like a pomalidomide or some other agent that we know where we could get some combined benefit. So
there is some literature out now that doing with the triplet, doing with pomalidomide.
Right.
And that was another question, but you've answered the one question I really have.
Okay, cool. All right, well, thank you. We're going to have to move on now and get to this last topic just so that we can get a feeling for this last point. So as I think most of the people on this call have been aware, there's been a lot of hype about this use of what are called the CAR T immune therapy treatments. And so slide number 29, just showing you that these engineered T cells bind to the cancer cell, in our case obviously the myeloma, and then can directly kill the myeloma. And so the T cells on slide 30 are white cells that can attack and kill cancer cells and viruses. And the way that this happens is by inserting a special receptor, chimeric antigen receptor, CAR, which in the pictures creates a tag on the surface so that the tag can bind to and identify the myeloma. And if we go to the next slide, number 31, the question has been which could be a good tag on the myeloma to go after. We do have some receptors that can be used, and there was quite an exciting abstract that was presented at our ASH meeting this year where these chimeric antigen receptor targeted T cells were prepared against BCMA. This is on slide number 31. So B cell maturation antigen. So this is something that is on the surface of the myeloma, and you can prepare the T cells to attack that. Now, the first thing you can tell just from the name of that is that it's B cells, and so this is not something that is 100% specific for myeloma. It will attack B cells, and so one of the key aspects of this technology is to have something that would target the myeloma but would be selective enough to not maybe eliminate other B cells or normal plasma cells or other cells that you actually do need. And so there was a lot of excitement about this, and it was a first-in-human phase 1 trial that was presented. You can see on slide 32, a small number of patients, 12 patients were treated. They also got some type of a chemo ahead of time to suppress the other immune activity so that then the T cells that have been engineered and grown up in the lab could be able to expand and take over and help to shut down the myeloma. And then if you go to slide 33, you can see, well, what was the response? And this is a very small study, 12 patients, but you can see that what caught people's attention was right at the top, stringent complete response. There was one patient that had a fantastic response, another one with a VGPR with the blue there, and then a couple of other patients had a partial response. And so it's clear that this kind of therapy can have dramatic benefit, and there's a lot of excitement about that. If you go to the next slide, this is creating a lot of hype, and it's been suggested that this is important because it could be active in patients with high-risk disease. And the question is this going to be the therapy we need to look at, or maybe we should not be looking so strongly at this approach? And so maybe, Rafat, maybe you'd like to take this one first. Do you think that this is going to be a strong way forward, or how do you look at this CAR-T therapy?
Yeah, this is very exciting. I started my career as an immunotherapy guy and gene therapy guy, so I actually like manipulating T cells.
Could we suggest that the very cute dog be muted briefly?
Yeah, it's probably post his opinion about CAR T cells strongly. But the truth. So let me actually address it in a different way.
All right.
When you get immunized for tetanus, you hope that your immune system will respond to tetanus. But when you immunize somebody against tetanus, they're not going to be able to fight, pneumonia, pneumococcal pneumonia. You have to vaccinate them against pneumococcal. And I think you try to allude to that. I mean, what we lack in current CAR T-cell therapy is our ability to find the right target to generate an immune response to. So that's, I think, one problem we have. The other problem, I think, CAR T-cells, these cells are manipulated in the lab. And the question is that, are you going to generate really very healthy cells? They can be dangerous down the road. We don't know. So what I'm really more excited about, and I think we may learn more about these drugs, is what we call the checkpoint inhibitor, the PD-L1, which are molecules that kind of wake up the immune system, make the immune system recognize our cancer as foreign, and enhance our immune system to fight cancer. It could be an easier approach than taking the patient's own immune cells, manipulating in the lab, and then infuse them back. Because that may not be a lasting response. Maybe that's a transient benefit. But if you stimulate the patient's own immune system, that would be fantastic.
Okay, good points. So, Vincent, what do you think about this?
Well, there's obviously this is the most exciting thing that immunotherapy people would have wanted, that is CAR T cells and checkpoint inhibitors being highly active in various malignancies. A CD20 CAR T that was published in the New England Journal of Medicine, and then this is another one. So we are all excited. I think the problem is going to be, trying to make it happen at centers. It requires quite a bit of infrastructure. And we also need proof that it actually works more than solitary case reports. So because there's multiple other treatments the patients are getting together, so we don't know how much the CAR T is contributing, as opposed to, say, the transplant or the cyclophosphamide or fludarabine. So some more things to be worked out, but certainly looks promising because, if you look at the ALL story, I mean, it's very, very promising.
Right. I would agree. But I certainly also personally pick up on Rafat's point that using the checkpoint inhibitor to enhance along with like DARA or, some of the trials that are being proposed right now is certainly a whole lot simpler and doesn't involve this complex technology. But nonetheless, all of these immune strategies are very, very exciting. So I think we have time for perhaps a last one or two questions. Any questions about this from the callers?
And again, if you would like to ask a question, please press *1. And you have quite a few.
All right. Well, I don't know that we'll be able to handle them all, but let's try.
Okay. Your first one comes from Judith Cohen.
All right, Judith.
Judith?
Yes, you have the floor.
Oh, sorry, I was on mute. My apologies. I want to thank you again for this conference. It was very enlightening. Two-part question, please. In regards to maintenance, what you would recommend, Velcade versus Revlimid, and if you select Velcade, again, due to the secondary cancers associated with Revlimid, and you end up with increased peripheral neuropathy, what would be your comfort level if you're able to get an Enlaro for maintenance?
Okay. Vincent, maybe you want to comment on that? I mean,
for choice of therapy between bortezomib and, say, lenalidomide or Velcade Revlimid, the way we have done it is like use bortezomib for high-risk myeloma and lenalidomide for the standard and intermediate. Bortezomib for intermediate and high-risk myeloma and lenalidomide for standard-risk myeloma. But let's say for whatever reason someone's already on bortezomib and responding or, being stable, but they're developing neuropathy, then I wouldn't have a problem going to an Enlaro if that's possible in terms of like insurance. Right.
I was thinking that. I think that we may end up seeing that more and more, and I think it is going to be a matter, as was alluded to by Jack Aiello earlier, if this is going to be reimbursed and covered, but certainly could be an option to get away from the neuropathy and also whatever concerns could be about increased second primary malignancies. So I'm going to move on, and so if we can try to have one last question before we close. So a last question?
And you have one from Vita Sullivan.
Okay.
Hi there.
Hello.
Yes. At this point of the game, do you have a specific plan for people who have genetic abnormalities? I mean, right now we treat everybody with this pretty much the same regimen, but is there a day that we could just look at the genetic abnormalities and say, you need A drug or B drug, not the C drug?
Right. So this is the precision medicine of the future, and I would emphasize the future part of that. I think that we're obviously not quite there yet in terms of selecting based upon molecular targets, which would be truly fantastic. But I think the good news about these immune therapies we've just been talking about, for example, daratumumab plus PD-1 inhibitor or PD-L1 inhibitor, I mean, those are going to be working even in the presence of high-risk chromosome changes within the cell. And so I think that there is a lot of excitement about that aspect, the ability to potentially overcome some of these molecular high-risk features. Would either one of you want to comment on that aspect?
Yeah, probably Vincent is better than commenting on that. But I think
you just in closing, is there anything you want to say about that, Vincent? You feel like that's the case, or anything in a closing comment about that?
No, I think it's very, very important that we recognize myeloma is not one disease. It's cytogenetically 6 different diseases. If you do profiling, you're going to find multiple more different diseases. But at least we have to make a start, and I've been arguing for risk-adapted therapy and risk-adapted trials, as well as response-adapted trials where based on the level of response achieved, then you make another decision on whether to continue, stop, or add another drug. And so we have to really individualize patient care. To some extent, we've got some answers, but we have a lot of ways to go. For example, we know that patients with 17p require bortezomib-based induction, transplant, bortezomib-based maintenance. Probably the same is true of 414. The other patients can do well regardless of regimen sometimes. And so there's some aspects of it we understand, but so much more to learn because we haven't done controlled trials.
Right.
Is there any suggestion for people with chromosome 1 abnormalities at all?
No, because all we know that is chromosome 1 abnormalities come in 2 shapes. One is deletion of the chromosome 1p, and the other is amplification or gain extra copies of chromosome 1q.
Right.
slightly adverse prognosis, but there are no good studies that say how specifically you overcome that.
Right. But I mean, different things are being looked at, and certainly some of these newer combinations probably do give some added benefit, but we don't know enough yet. So, all right. Well, I think that we've reached the end of our hour, and appreciate very much my colleagues participating tonight. So thanks to them and for your excellent questions. And so I'm going to turn it back over to Susie now, who will have some closing comments.
Well, I want to thank Brian and Vincent and Rafat. I think that was really wonderful, and I'd like to thank everybody that joined us on the call tonight. I thought it was outstanding. I may be a little bit biased, but it certainly was very informative. So I'm sure tonight you're going to have a lot of questions, and so I suggest that you call our info line. They're always here to help you, and the toll-free number is 800-452-2873. Another really fantastic way to stay abreast of all the new data and how it impacts your treatments is to attend one of our patient seminars. Our next one will be in Philadelphia, April 8th and 9th, and then the one after that will be right here in Los Angeles, August 19th and 20th. And if you can't make it to one of those, my colleague Kelly Cox is holding regional community workshops all across the U.S. So just go to our website and see if there's one coming to a city near you. And I'd like to once again thank our sponsors, Amgen, Bristol-Myers Squibb, Janssen, and Takeda Oncology. And before we close, I really just want to also give a shout-out to our wonderful support group team here at the IMF, Robin, Kelly, Nancy, Sue, and Ann, who work with groups all across the country, helping you in so many positive ways. And we're definitely taking action and making March matter. So that's it. Have a wonderful evening, and I hope to see you all soon. Thank you.
Thanks to you all. Have a good evening.
Good night.